precordial leads, and then take that as a ratio over the total QRS, you get what was called by the Daniels group, by Dave Wilbur's group, as the maximum deflection index. And when it was more than 0.55 or 0.46, this one 0.59, in our particular patient, 0.6. This basically describes this extremely slow upstroke and takes you more to the epicardium. So when you've mapped the endocardium and you haven't found a good site, this analyzing the ECG is going to take you a bit more quickly to the epicardial surface. And this is a pace map from the epicardial surface on this particular patient done by my colleague Pablo Neri, showing a pretty darn good match on the epicardium when they found nothing on the endocardium that was good. And there's the LAO showing the catheter all the way around the coronary sinus, right to where the great cardiac vein dumps into the distal portion of the coronary sinus. And here's the local electrogram. Eugene will tell you more about this, but another one, same story. Wide QRS. I'll show you this in almost looks like a delta wave. A very slow upstroke with a high MDI, epicardial. MDI more than 0.55. Okay? The ECG is critical. You have to look at the ECG before you go into a late VT. Eugene, I think you're going to talk a lot about this, are you? You're going to talk about the ECG? Or only endocardial? Pardon me? Okay. So in coronary disease VT, if you see left bundle branch block morphology, usually a septal origin. If you see a frontal plane axis that is inferior, think that it's arising from or at least the exit is rising from the top of the scar. If you see a superior axis, think that it's arising from the bottom of the scar. This is critically important and easy. You have to do this before you go into the lab. You look at the precordial transition. If the transition is if you see, for instance, a lot of positivity in the bunch of precordial leads all the way down, it's going to be more basal. If you see QS complexes, for instance, down in V4, V5, V6, it's going to be more apical. It's very important that you look at the ECG before you go in. This is one of Frank Marczlinski's slides showing paired VT morphologies at similar cycle lengths, same patient, a left bundle, left superior axis, and a right bundle, right superior axis. And this was, in fact, over the same area with paired morphologies. Very important. It identifies a large VT circuit, and in this particular case, you could actually get both VTs through the same area. Devices. I'm sure David's going to tell us more about this. We need to understand device behavior, and the ECG helps us. This is a patient recently had their pacemaker put in. The nurse calls you saying, pacemaker's not working. And in fact, you have to analyze the ECG. This is MVP. This is one of the pacing avoidance from, in this case, Medtronic. This is normal function. Our fellow proudly put in his pacemaker, proudly came up and didn't look at the angulated views and didn't look at V1 while he was putting in the pacemaker. And here's the ECG after he put in his pacemaker. So he, not so proudly, shrunk back into the lab, went and did an X-ray on the patient. And in fact, in the lateral X-ray, you can see that it comes through an atrial septal defect. It's a very high and then down into the left ventricle. And in fact, of course, we were pacing the left ventricle, as you can see from the previous ECG, with a tall monophasic R wave in V1 and VT, showing left ventricular pacing. And he sheepishly, after he proudly did it, sheepishly, we had to go back to the lab and put it in the right ventricular apex. And this identifies typical RV apical pacing. Now, I'm an electrophysiologist, electrocardiologist, electrocardiographer, but I'm going to also argue that the electrophysiologist is probably needed in the device lab. This is a tachycardia, and there's a little oversensing in the atrium, and I won't go into that. ATP is delivered. And if you follow the A, you can see why there's oversensing in the atrium because of the V. If you follow the A, the last two are accelerated. So in fact, you're able to accelerate the A to the V pacing rate, and the next thing that happens is an A. So in fact, here is failed ATP, which shows a VA, VAAV response. So you need to be, I hate to say this, but you need to have electrophysiology training. You need to want to study rhythms. You need to want to study electrograms and electrocardiography to recognize this is diagnostic of an atrial tachycardia. Diagnostic of an atrial tachycardia. This isn't VT, and you even know what kind of tachycardia it is. So, beautiful example of how studying the ECGs and the electrograms bring us to the correct diagnosis. Blocks. Well, this patient has right bundle branch block and 2-to-1 block, but there's an acute inferior infarct. But I want to bring to your attention the extremely long PR interval. And that extremely long PR interval almost always goes along with proximal block. And in fact, this is likely to recover, and this patient is not going to require pacing. Atrial fibrillation with complete heart block. If you don't study the ECG, the nice regular rhythm isn't necessarily, and this patient actually was a 91-year-old man with syncope. Why back to the ECG, inherited arrhythmia syndromes? I did this on the last one, but it was a good example of an epsilon wave in a patient with ARVC that we missed, and I say we because that includes me on the first look when this guy came in. First look, I missed this, as did the rest of my team. We got it on second look, though. Another one, I showed this on the last one. This is a typical ARVC ECG, long QT syndrome. You need the ECG, short QT syndrome. Actually, sorry, this is a Brugada. These are all diagnosed by ECGs. You have to study the ECG. And this is the one where we placed it one interspace higher, showing this anatomical variation in the ECG. This is Torsade associated with complete heart block. This is ischemic VF. This is a completely different polymorphic VT associated with ischemic heart disease. If you just call this Torsade, because it looks like Torsade, it's polymorphic VT. You even have some twisting. If you call that Torsade, you'll be wrong. It's a different treatment. It's a different disease. This is a short-coupled PVC on a normal QT interval. The previous one is a long QT interval with a late-coupled PVC following a pause-dependent initiation. The difference is the difference between the right treatment and the wrong treatment. And lastly, because it's fun. We should never forget that one. We want to challenge ourselves. We want to we want to make this fun. We want to make this fun for our colleagues and our students and our seniors. We want to look at ECGs that show, for instance, atrial flutter with 8-to-3 conduction and ask yourselves the question, why is that? And then we think, well, Wenke back is typically n plus 1 to n. So if you have 3 outputs, 1, 2, 3, pause, 1, 2, 3, pause, it would generally be 4 inputs to 3 outputs. That's a typical Wenke back sequence. But here we have 8. So we've identified bi-level block, 2-to-1, 4-to-3. 2-to-1, 4-to-3 gives you 8-to-3. And this goes on forever. This is not random. This is not variable conduction. This is 2-level block. Does anyone care? Well, I do. It's fun. It's fun to think of this. It's fun to sit with your residents and your fellows and show them this ECG. Here's another one. Here's a 6-to-2. Same thing. 1, 2, pause, 1, 2, pause, 1, 2. This is 2-to-1, 3-to-2. This is atrial flutter with bi-level block. And lastly, the last ECG I'm going to show you is one we saw recently. This is a failed ATP in a patient who comes into the emergency room with his defibrillator, still trying to pace him out of out of his tachycardia. After he'd already received another couple of shocks, he was okay, came into emerge, hooked him up to the ECG machine, and he had another episode of VT with ATP. But I want you to focus on this beat right here. This, you see here we have ventricular pacing ATP, which fails. And all these beats look the same, and they must be fused. But what I want to show you is that this beat here actually is the first beat of ATP, and this is also fused. So we've actually captured a portion of the left ventricle or the right ventricle with this one. Well, I don't know which one, but I do know which one. Because the next one looks exactly the same as all the subsequent ones. So in fact, this paced beat, its wavefront, not only captured the local right ventricle and intervening left ventricle, but actually got into the circuit because all the subsequent beats are equally fused. So it meant that we've entrained it with the very first beat, but we're unable to terminate it. Who cares? Well, it's cool. That's who cares. So let me just argue that we have a lot of reasons to go back to studying the ECG. Most importantly, it's because we'll practice our specialty better, and we'll do this before we go into the lab, as in VT targets, and maybe even instead of going into the EP lab if we identify these correctly. Thank you for your attention. Hope I've convinced you.
Thank you, Dr. Green. We all enjoyed your talk, and we agree with you. It's fun to learn from ECG, and it's add more fun if you try to ablate and learn while ablating. Thank you very much. We'll move on to the next speaker, Dr. David Hayes. He's a director of the Device Clinic, a chairman of Cardiovascular Division in Mayo Clinic, Minnesota. Dr. Hayes.
Thanks very much. So in the next few minutes on the challenging CRT cases, I've got 3 cases, 2 of which are post-CRT, 1 is pre-CRT. And the first one, which I used in the last session, I'm going to use it here because for my own edification, I'd like some input into what others would do. But 2 things I'd like to talk about briefly first is that if you have not looked at this article from Mullins, this is from the Cleveland Clinic, Bruce Wilcoff is the senior author. If you've not looked at this article, the citation was in JACC last year, on their CRT optimization clinic. This is really an excellent article. I talk a lot, if I talk about pacemaker electrocardiography or radiography or anything else, that you've got to have a systematic approach. And after looking carefully at this article, decided that my approach for CRT non-responders was not as systematic as it needed to be, because they've really done a beautiful job in the way they approach these patients. But if you look at their data in terms of why CRT patients would have a suboptimal response, listed them all here: suboptimal AV timing, arrhythmias that are preventing you from having effective biventricular stimulation, anemia, poor positioning, inadequate percentage of biventricular pacing, and I'm going to come back to that later, persistent mechanical dyssynchrony, suboptimal medical therapy, underlying narrow QRS, that is, they didn't have significant dyssynchrony in the beginning, compliance issues with medications, or primary right ventricular dysfunction, and then